callers, and not necessarily those of this station, its staff, management, or sponsors.
Welcome to the Ask the Experts show with local experts in the fields of legal, health, financial, and home improvement. Enjoy being educated in such topics as personal injury law, community association law, family law, bankruptcy law, along with health show topics like pain management, men's health, and dental implants. Now, sit back and enjoy today's Ask the Experts with host Steve-O.
And we are here tonight with Dr. Eric Shenvin on Ask the Expert. I'm Rhonda Hines, and tonight we're going to be talking about erectile dysfunction. So, Doctor, you have a lot of experience with ED. That is your specialty, would you say?
As a urologist, we're the male genitourinary experts. So that is what our training is based in. The genitourinary system does include some female stuff as well, with urinary incontinence and overactive bladder, and both men and women get kidney stones and bladder cancer. But when it comes to the male genitalia, the gynecologist is more of the expert on that side, and we are the experts for the male side.
So you're a male gynecologist.
You could say that.
So what are some causes of erectile dysfunction? But welcome back, by the way. I forgot to welcome you back. You've been on vacation. Where were you guys at?
We were in Park City, Utah, skiing up a storm.
Oh, tough life, Doctor. And how was that?
It was terrific. I was there with my family. We got about 14 inches of snow a couple days, and it was just our first time in Utah. It was great.
So you guys are big skiers?
Well, we're once-a-year skiers. Great vacation with the kids.
Yeah.
A lot of fun.
Your kids are teens or?
14 and 16.
Okay, so they travel well. Talk back a little bit. Right?
Sure
Is that
do.
the problem you're having?
This was the first time they were only in ski school 1 out of 4 days of skiing. Usually we have some time to ourselves while they're in camp or ski school, whatever you want to call it.
So you didn't get to rekindle the honeymoon.
Not quite this time.
So as we were leaving off and talking about, what do you think or what do you know are the main causes of erectile dysfunction?
So there's a lot of causes. I think one of the important things for men and women to know about themselves or their partner is that it's nothing to be ashamed about. It's a very common thing. And we're not talking about the once in a lifetime or that everyone experiences at some point in their lifetime with anxiety and so on.
Performance anxiety, first time?
Certainly performance anxiety, that anxiety will rekindle itself the next time, only making it a little harder, and it's just kind of getting out of your head.
Yeah.
To get over that. But I think we're talking about really the long-standing, more permanent and debilitating problems that cause ED. And
Which you do bring up good points. I mean, men have to be very focused. I mean, there's a lot of mental work that goes into it, wouldn't you say?
I'd say the less you think about it, maybe like playing tennis like my son, the less you think about it, the less problems you're going to have if you don't have any inherent physiologic problems bringing you down.
Right.
So I think that the big ones are vascular and neurologic. Diabetes is a huge one that's out there. High blood pressure, low testosterone, another really big one. Other smaller vascular and neurologic disorders can certainly have an effect.
How does cortisol affect erection?
So cortisol can affect your testosterone level, and stress, physical and mental stress, can raise your cortisol levels and thereby suppress your testosterone levels. And we know that testosterone is needed for normal erectile function. And when the cortisol is too high and suppresses your testosterone, that can result in ED because of the lower testosterone levels. And that oftentimes is acute and may very well correct itself if any of those physical or mental issues causing a lot of the stress, which is why we say anxiety sometimes, but if people are having a lot of mental stress and strife in their life, could be good stress, could be bad stress, getting married, having a child, moving into a new house, good stress, but a lot of stress can certainly bump over those cortisol.
It ain't good stress if it ain't working in the bedroom. That's supposed to be stress relief.
Absolutely.
So let me ask you, the lab ranges, and I think we might have talked about this before, the lab ranges are so wide, so what might be low testosterone for one person may not be for another. Wouldn't you agree those lab ranges are so wide that someone could be affected?
The lab ranges are very old and outdated and really are longing for probably a nice academic center or conglomeration of multiple sites to really come up with some new levels. I think those levels took into account a lot of men, younger or certainly older, whose levels were getting low, and there's really no way that those levels were justified clinically as to whether these men were suffering from symptoms of low testosterone at this wide range of numbers. So I think you have to take a good history and not just look at the number, but speak to the patient. And there are a number of patients that have low testosterone levels and no symptoms, and some patients that have normal, what I would call normal in that maybe 500 to 900 range, a little tighter, 6 to 800.
Yeah.
But everyone's a little different, and have ranges in what I call normal, but are still symptomatic and would require a little more analysis.
What's a good average normal testosterone range?
I think that 500 to 900 range, generally, we certainly look at treating below 300 if the patient has any symptoms. And a lot of times, even into the lower to mid 400s, if the patient has clinical signs of low testosterone.
Yeah.
And sometimes you'll have patients that get diagnosed because they were found to have osteoporosis.
Wow.
Not just sexual dysfunction, depression, and...
What are those other symptoms of low T?
Well, certainly we have the sexual ones. We talked about the ED, the low mental sex drive, low energy,
So
really
they just don't
dragging
crave
through the
sex
day.
anymore with low T.
Exactly. And men tend to notice it more than women because men tend to have a higher sex drive.
You bet.
And it certainly...
Unless they're with a woman in their 40s.
Well, it certainly can come no matter what. I have patients in their 80s and women in their 80s. They're more the minority, but certainly I have patients and couples in those situations. And a lot of times it comes from the spouse. And I like having both partners in the office with me because sometimes the man is not going to be the one talking about the real problem at hand, which is not just the physical sexual part, but the relationship part of it, the intimacy of their intimate relationship.
You mean they're just too embarrassed to talk about there's a problem?
Men might be embarrassed or they minimize the problem for whatever it may be.
Or the number of times it's happened?
For sure.
Yeah. What do you find that high cholesterol, high blood pressure, do those have an effect on performance?
I think if we look at the cholesterol and the blood pressure, and even in diabetes in that factor, and we think about atherosclerosis, clogged arteries, we always think of the heart.
Pressure change?
Sure. But we always think about the heart and heart attacks and heart disease and heart bypass and stents. But we have to remember that the arteries to the penis are much, much smaller than the arteries to the heart. So they're going to clog up first, and that's why ED or erectile dysfunction can be a sign, a harbinger of heart disease to come.
So the arteries around the penis clog?
Yes.
Okay.
Yes. And
With
remember,
bad cholesterol?
with too high cholesterol levels, certainly there are genetic hereditary factors that get passed down that put some people more predisposed to these problems. And
Avoid that candy bar. It may affect your penis.
well, certainly, I think with all of this, you bring up a good point, is diet. And I talk to men about their diet and their health, because certainly if we have these problems and we can find a little more of the source and fix the problem of the ED, or certainly improve upon it, if we know the causes may have been poor diet, high blood pressure, diabetes, if you're not going to change your diet, start exercising. We know that exercise can increase testosterone. It can improve your good cholesterol
How
and
much
lower
can
your
it
bad
increase your
cholesterol.
testosterone? That's a good.
I don't
good
think
motivator.
I don't think I've ever read about specific numbers or a study that really showed just how many points it can go up, but I've definitely seen men over 100-point change. And again, that's a little more anecdotal.
It's also
Patients
mood. You
here
get
and there.
endorphins from it, so it relieves stress. So kind of a twofold benefit, right?
Absolutely.
So is it more the weight training or the cardiovascular types of exercises that improve their testosterone, or both?
I think it's a combination of both. Certainly, I think from an overall diet, I've learned a little more outside of medicine. We never really got taught any great amount of nutrition and exercise, physiology, and health
Right.
in medical school, and I still don't think they really do much of it at this point. But if you pursue it a little on your own, learn a little bit more about it, that combination of cardio and weight training is something that can help your overall physiology, your metabolism, weight. Weight is a big factor. Obesity. Obesity leads to sleep apnea. Sleep apnea can lead to lower testosterone.
You bet.
So it's this whole
Vicious cycle.
and vicious cycle that people can get caught up in. And it's really educating and certainly coming from your primary care doctor about good health, exercise, at least that 30 minutes, 3 times a week. And it's much easier to prevent than what everyone wants to do is backpedal and catch up and try and repair everything that they've damaged over time. And when you are diabetic, you got to keep those sugars in tight control. When you're hypertensive, high blood pressure, you got to keep your blood pressure in control and take your medicine and follow up with your doctor and check your own blood pressures. All of this is real important to your overall health, your cardiovascular health, if you will. And we know the erection comes from dilation of the arteries that lets the blood in,
Yeah.
and the nerves tell the arteries to do it.
Yeah. Good health equals good erections.
I think that's a good point.
That's a healthy way to say it. You bring up a good point about diet. The government recommendations for what healthy eating is. You should see the numbers of sugars and what they're giving kids in schools. I mean, we don't have a lot of good government information on correct diet. And I think, like you said, in medical school, you weren't really taught and given a great curriculum on what proper eating was. You just kind of figured it out on your own. Makes sense. So it's good that you actually take those steps and you work with your patients to figure out what's the best, eating plan and meal plan. Do you kind of guide them and give them like a nutritionist, or do you have someone you work with?
I have sent a couple of patients over to a nutritionist. I have even I know it's the mental side, but a couple of sex therapists, psychotherapists.
For the mental aspect?
For the mental aspect.
If you find
and
that it's an emotional mental component?
there's emotion, there's the depression that can result from a low testosterone or embarrassment. Certainly there are some people who have histories of abuse, sexual, physical, and otherwise that get in the way of intimacy, and then the anxiety from that results in more of a psychogenic erectile dysfunction. So
Do
there are a
patients
lot of
share that with
factors.
you? When you do the intake, do patients open up that way to you?
Some do. I had a patient recently that I've known for 5 to 10 years that only just recently told me about something from childhood.
Yeah, I think particularly with men, there's a lot more. I mean, I think with a lot of people, they carry the shame, but I think with men particularly, I don't think there's open about that. Like you said, it's kind of a don't ask. You told me earlier, don't ask, don't tell policy when you're trying to get information from them. Just more guarded.
For sure.
Yeah. Well, give folks your phone number and your website.
Our website is our practice name, which is Broward Urology Center. We're located in downtown Fort Lauderdale on Andrews, just off of 595 and 95 in between Route 84 and Southeast 17th on Andrews. Our phone number is 954-463-6408. Almost forgot it away on vacation.
Yeah, you went away for a week and just everything went. But you know what? Good for you. I'm sure you needed it. We're going to be back after this short commercial break, and we're going to continue to talk about erectile dysfunctions and who has it, and what we can do to treat it. We'll be back.
Are you suffering from erectile dysfunction, also known as ED? The urologist at Broward Urology Center can help men regain their sexual health in a comfortable, discreet environment. ED can result from age, low testosterone, high blood pressure, diabetes, smoking, sleep apnea, high cholesterol, and cardiovascular disease. When a man is first seen in the office at Broward Urology Center, a thorough evaluation is done by the doctor, which begins with an open, honest, and absolutely confidential discussion about their overall medical health and current sexual function. A complete physical exam is performed, and blood work is often ordered. Once a full workup is completed, a customized treatment plan is designed for each individual patient. They offer all treatments for ED, including the newest shockwave therapy and the P-Shot. Contact the Broward Urology Center today to discuss all the different options they offer for ED at 954-463-6408.
And we are back with Dr. Eric Shenvin from Broward Urology Center. You know, doctor, we've talked about a lot of causes of ED, but who are the folks that can have it? Who does it affect?
So it can affect most any men, really. Doesn't matter race, age. I would say generally the youngest I've seen are some men in their 30s. Certainly I'm seeing more and more in their 40s and 50s, and all the way up into their 80s and 90s. Believe it or not, I have men in their 80s and 90s that newly married, new relationships.
Love
Maybe
it.
it's just South Florida, but they're
in the mood for love.
they may not want to they may not want to have sexual relations every day, but if it's once a month, then it's real important to them and their partner, and they want it to work at that one time once a month.
And if it's only going to be one time, that's a lot of stress. You got to get it right.
exactly,
Right?
exactly.
So, have you ever seen anyone in their 20s affected?
I think I've seen a couple people, and they're a little harder to figure out, and you become a little more worried about what may be going on with them physiologically.
Like testicular cancer? Was it something related to that?
No, but other hormonal issues and imbalances. I usually send them to an endocrinologist for a full endocrine hormonal kind of workup. There's some of that more detailed hormonal aspects that I don't handle, that kind of gets out of my field of specialty, and I call for some help from my colleagues on those.
Yeah.
And
if that's what it ends up being, it's usually just a complete hormone imbalance. That
some of them we just don't figure out. That there are just some people that may have some type of neurovascular problems that we just can't put a finger on and determine the cause. And like many things, just like blood pressure in and of itself, essential hypertension, because we essentially don't know why it's happening in most of the patients.
Oh, with
So
hypertension, they don't know what's causing that
Most of the time we don't.
Hmm.
And you just end up treating it and trying to optimize the patient.
Mask some symptoms and then create some other problems sometimes,
Sure.
right?
I think in younger men, though, low testosterone or outside sources, sometimes drug use, can result in the erectile dysfunction. Even alcohol certainly can be a factor that I think younger men don't realize or think of. And
Yeah.
as certainly all men, low testosterone can be an issue, but we think of that especially as men get above their 50s and 60s, because I think there are a lot more men than we realized who, for one reason or another, develop a sort of almost a pre-programmed andropause or a male menopause. And
So it's real.
Testosterone goes down. It's real, but the interesting thing is, unlike women where it's almost 100%, it's very diverse in men.
You mean like
And
when it starts, or
from when it starts to how bad it can become, or if at all. Because I certainly have men in their 80s with good testosterone levels and normal erections.
God bless them?
God bless them. I mean, they're the minority, but they're working better than some of my 50-year-old patients.
Wow.
So I think it spans the full breadth of life, but
Yeah.
I think it's important that people know there's a lot we can do about it.
Yeah.
And it's not something to stay behind doors and throw away that intimate part of your relationship with your partner, because that's what makes that relationship different than even your best of best friends.
Yeah.
Is that intimacy
Physical,
that you
yeah.
share.
And do you ever have cases where you've treated people who've had like excessive steroid use, and what have you seen that do to those men?
So unfortunately, there's definitely steroid, which is really testosterone and some other types of steroids out there, abuse, and really anyone using it. It's I don't know if you can say using cocaine just on the weekends is not abuse because it's a drug, but you're just using it in control, so to speak. And I think the anabolic steroids is the same thing. Some of the trainers have really developed a methodology that even the endocrinologists are not familiar with, where they've learned how to kind of cycle the steroids and rescue the body from not completely shutting down its production because it's getting it from the steroids. But the end result in some of these men is the testicles never recover the steroid synthesis production, and they end up having very low testosterone, and they are difficult patients to treat.
And they're difficult because
they want everything. They tend to be young in their 30s and 40s and 50s, and they want everything and think everything should just work normally, and they're going to need testosterone replacement for life.
Oh.
And certainly, other men develop that, like I mentioned, physiologically on their own, but this is kind of forced, sort of like when a woman has a hysterectomy and the ovaries removed and there's no longer estrogen around.
Yeah.
So you're sort of forced into menopause. Same kind of thing here. You're really shutting down the factory.
So, Viagra is a standard on the market, but what are some other treatments that you offer for erectile dysfunction?
So the pills are out there, and they are a great option since Viagra hit the market in the 1990s, and very easy for someone to pop a pill, although there are plenty of side effects that patients can get, debilitating headaches, to have an erection but feel like your head's going to rupture really doesn't make the moment any better, leg cramps, upset stomach, some visual changes, lightheadedness, different things. Not that everyone gets these, but certainly it's not perfect. And there's the old school injections and the newer stuff that I've been doing for the last couple of years now, the shockwave therapy and the PRP or the P-shot, the platelet-rich plasma injections are coined regenerative treatments, as these are treatments that are trying to bolster the body's own immune system and healing process and sort of force that healing where it's needed, and in this case, in the penile tissue, and get things really repaired and working back to the way they were. And
how effective is that?
The numbers that are reported are in the sort of generically speaking 75 to 80% range, and I think again,
that's pretty good numbers.
The numbers are decent, but I think we also have to look at the patients and with time get some better statistics and stratification, because the level of dysfunction in one man may be very mild, moderate in another, and very severe in the last. And I think as the urologist, we have the tools to really best evaluate that a lot of the other doctors that have started doing some of these regenerative treatments really just treat patients one for all and one size fits all. And you just can't do that, because there are some of these patients that nothing's going to work for them, and you need to evaluate them and give them the honest, upfront opinion.
Yeah.
And maybe those are going to be the patients that you consider for a surgical implant, which is an option and a good option when necessary, but I think we have a lot of other stuff out there to offer now.
So just describe the surgical implant. I think you said you just did one this morning.
The surgical implant is, again, it's in the operating room, done under general anesthesia. It's a same-day surgery. And the most common type of implant that's done now is a pumpable or inflatable prosthesis, where channels go into the natural bodies in the penis that fill with blood. So these channels or these tubes get placed into the penis, and there's a reservoir.
So in addition to their own tubing, they're getting additional
in other
tubing.
words, inside of your tube, we place the plastic rubber kind of tubes that are going to fill with saline, which usually gets stored in a little bulb or a little reservoir behind the pubic bone. It gets
Yeah.
tucked away in the lower pelvis behind the pubic bone, and then there is a pump, a small little ball or a bulb that goes in the scrotum next to the testicle. So you have to remember which one to squeeze and which one not to squeeze. But
So they're squeezing this during sex.
well, to get the erection, they're going to squeeze it, which will open a valve and release the sterile saline in the reservoir behind the pubic bone and allow that to travel through tubing
So on the side
into
of
the
their penis,
channels.
they're pumping this.
Correct.
Just trying to get a visual.
So a little bit like the old, for those old enough to remember the Reebok pump on the sneakers that you used to be able to pump up and fill the bladder, that made it fit a little better and so on. You're filling these cylinders with saline that then now not just expand widthwise, but they have ones that can expand a little bit lengthwise too, which was always something we were falling short on until the last 5 to 10 years or so. And
How often do you have to replace your pipes?
there are mechanical issues with it, and figure about every 8 to 10 years you can have mechanical failure with some part of the device that needs to get replaced.
I mean, I can see that definitely being a nice option when there are no options. At least it's something. But yeah, that could be tough. I mean, how long does it take them to inflate and to send the saline up the tubing?
Seconds.
Oh.
It's seconds. I think what I generally tell men though is if I can get their own equipment working back to normal or as close to normal as possible and be full and functional for them sexually, that both partners are certainly happy and satisfied, that I think they'll be happier than they would be with that implant.
Yeah.
But for those who can't and their physiology is just no longer going
Yeah.
to work for us, then certainly the implant is a good option.
I like that you're conservative and that you do try to kind of stick with the more natural and, only drugs when you need it and only surgery when you need it. I think that's important.
I think it comes from maybe my my minimally invasive training and fellowship. I did a fellowship in laparoscopy and
Nice.
endoscopic urology. So I always think of things going from less invasive to more invasive.
Yeah. Well, give folks your phone number one more time here.
It is 954-463-6408, and Broward Urology Center is our name, and practice.com. You can find us on Facebook as well.
As always, Dr. Shinven, it's been a pleasure, and thank you for coming and sharing with us about what you do and educating us.
Thanks for having me, Rhonda.
We'll see you next time. We'll be back after this short commercial break.